This is Crystal Fenn with MedPage Today. I'm here in San Francisco at the American Society of Hypertension meeting, where researchers reported that for blood pressure, lower isn't always better. Researchers led by Dr. Franz Messerli of St. Luke's Roosevelt Hospital reported these findings at a press conference.
Well, it stands to reason that when you lower blood pressure too much, that you can do harm. After all, if blood pressure is 0, mortality is 100%. So somewhere there must be a nadir at which lowering of blood pressure becomes counterproductive. And we had shown and published in the Annals of Internal Medicine about 2 years ago that in the INVEST study, in which everybody had coronary artery disease, there was indeed such a J-curve, more pronounced for diastolic than for systolic pressure. Similarly, now in a study in which there was lipid management, and I'm talking about the TNT, we did find a clear-cut J-curve. The nadir for systolic blood pressure was around 140, 139.7, and for diastolic blood pressure it was fairly high, actually in the 80s. So the good news is that it is a relatively shallow curve. You can go down quite considerably more before you actually see a drastic increase in the primary endpoint. But when you go to a diastolic pressure below 60, you have a 4-fold increase in the primary endpoint. Now, you can say, there are several explanations of this phenomenon. Explanation number 1 is obviously what I just said. You lower blood pressure too much, you underperfuse the coronaries, and therefore you paradoxically, so to speak, increase the risk of having a heart attack. That's explanation number 1. Explanation number 2 is that a particularly low diastolic blood pressure means that the pulse pressure is high. When pulse pressure is high, we have endothelial dysfunction, we have stiff arteries. So these patients have vascular disease, and that may be the reason that they have a higher morbidity than mortality. And explanation number 3 is the so-called reverse causation. Patients who have low blood pressure have concomitant pathology, i.e. cancer or cathectic and so on, and that's why they die more than patients who have a blood pressure that's a little bit higher. Now, we cannot 100% rule out all of these hypotheses. They are somewhat unlikely by a lot of statistical tricks that we have done, but these are statistical manipulations, so we cannot rule them out.
Dr. Messerli said that the J-curve seen in this trial of patients managed for lipids but not blood pressure was remarkably similar to the curve seen in other trials, again affirming that this is a real phenomenon. I'm Crystal Fenn, MedPage Today.